Olivia. I'm a fourth-year medical student at the University of Iowa, Carver College of Medicine, and I'm applying right now to anesthesiology for this year's match. So that's a little bit about me. I've been doing virtual rounds since May or June of 2021, and it is one of my favorite things to do. And today we are going to be talking about an immunology topic and going over anaphylaxis. This is something that I think everyone, regardless of what you end up going into, but especially people who are going to be in healthcare and in medicine, should have a knowledge about. But even the general public, I think it's great to have a background or be able to at least recognize when something is going wrong, so that you can get someone help if they're experiencing anaphylaxis. It's a very scary allergic reaction, as we'll learn in the coming hour, and it can be treated if caught, early enough, and hopefully get people to the hospital and get the care that they need. So without further ado, we will get going. As always, we'll have a simulated patient case and go through like the patient's physical exam, a differential diagnosis, and come up with an assessment and plan for them. And then the second half will focus on the pathology of disease and do a little bit of background in immunology. So please, like I said before, participate, ask questions. You can put it in the chat if you don't want to unmute yourself. Ask questions, or if I have a couple questions in here that it'd be great to hear your guys' thoughts as well. So feel free to do that. And then I also put in the chat our SOAP note and quiz link, which is the Google Forms one, the second link. So you can be working on filling out the SOAP note as we go through it, and then do the quiz at the end of the session. And I also have the Google resource drive. So if you have any questions about like terminology, of course, please ask during the session, but you can also see a lot of medical terminology and things like that in the resource link. So this is what the form looks like. Starting off with our case, we have a 20-year-old female who presents to the ER with sudden onset of wheezing and shortness of breath. I've said this before in previous virtual round sessions, but if it's your first time, sometimes, especially in like an acute setting, like the emergency room or urgent care, all we get is like a one-liner about the patient. So it's good to start thinking early without any additional information, what would be some ideas of things that could cause this, so that we have a really broad differential diagnosis and then can kind of narrow it down as we get more information. So I'm going to challenge you guys to come up with what are 3 things at least that can cause wheezing or shortness of breath. We have asthma in the chat. 2 people say asthma, which is absolutely correct. Especially with the wheezing, that's like a classic asthma symptom. Can we maybe get 2 more things that can cause either of them? Traumatic injury, exactly, yeah. So if they have maybe like a trauma that caused like a pneumothorax or something. Anaphylaxis, Chase, of course, yes, because this is anaphylaxis talk, so it kind of gives it away a little bit. And allergies too. So like even a hay fever or allergic rhinitis can cause shortness of breath in some cases as well. So perfect. This is my short list of stuff that I kind of came up with. As always, it is not exhaustive. There's plenty of other things that are not on the slide that can cause wheezing or shortness of breath. But I like to kind of break it down by system. So the most obvious one is the respiratory system, because that's what's, your airway and your lungs are the kind of primary anatomy that can be affected in wheezing and shortness of breath. So asthma exacerbation, that was the first thing people said. COPD, less likely for this person's age. COPD, or chronic obstructive pulmonary disorder, is something that we think of more in like middle age or older people, especially who have a history of smoking. So probably not this person, but can present with similar symptoms. Infection like the flu, influenza, COVID, RSV, any of the respiratory viruses, or a bacterial infection like pneumonia. Trauma, someone said trauma, for example, like a pneumothorax, where you have a collapse of the lung due to a puncture of the pleura, or the lining of the lung, that can be brought on by trauma. So more of an acute presentation there. Cardiovascular, the one that I would especially think of in this type of a patient with shortness of breath, a young female, it would be a pulmonary embolism or a blood clot in the lungs. Just statistically, women are more likely to get blood clots, and maybe she's on like birth control pills or something that can also increase your risk for blood clots. Less likely again, but wanted to keep it on the list, is something like heart failure or heart defect. If she has like a prior history of heart disease, that this could be like an acute exacerbation of that. And then in this other category, we've got kind of a conglomerate of things. I always want to include something psych on the list to not forget about, because people do tend to forget about it sometimes. And maybe this patient has like a history of anxiety or a panic disorder, and this is a panic attack. And that we need to treat differently for a mental health cause versus a physical health cause. Anemia, which is low hemoglobin, that's a blood disorder. So something that in your red blood cells, you can't carry oxygen as well, can actually present with shortness of breath because your lungs are having to work harder to get more oxygen into your bloodstream. And then we did mention allergic reaction and anaphylaxis. That's sort of a more like systemic immune type cause of shortness of breath and wheezing that, of course, especially with this case, we want to consider. And again, many more that are not on the slide. So a little bit more information for us to work with. The patient that we're seeing had this occur shortly after she was stung by a bee while she was watering her garden, which was about 25 minutes ago. So asking about like, what are associated events that happened around the time that you started having your symptoms? And for this patient, very clearly, we can identify that a bee sting happened around the same time, and it's reasonable in this case to associate those two as being connected. This shortness of breath and wheezing was preceded by a tingling sensation of her lips. And she's never had this happen before, but her sister has had something like this similar happen because she's allergic to peanuts. And for that, she needs to carry an EpiPen or an epinephrine injector when she has similar symptoms. So family history of allergies and anaphylaxis, definitely something to keep in mind, that this patient might have, again, higher risk for that type of allergy. Some additional subjective history here for the SOAP note. Her past medical history is significant for allergic rhinitis or hay fever. That's kind of the colloquial way that we talk about like seasonal or environmental allergies to pollen and dust. It can be a range of things, pet dander, anything like in nature, like grass, trees, weeds, really like anything people can be allergic to if it's in the air. And she also has a history of mild intermittent asthma. So for her medication, she is on an oral contraceptive pill for birth control, and she also has an albuterol inhaler for her mild intermittent asthma. She doesn't have any surgical history, and for her family history, like we mentioned, her sister has a peanut allergy that requires the use of an EpiPen, and her mother also has Graves' disease, which is a hyperthyroid disorder and also an autoimmune disorder. So that's a little bit of background about Graves' disease. For social history, our patient is currently in nursing school at a local community college. It's always nice to have some background on your patient to both help you build rapport with them and remind yourself that they're also a real person with life events and goals and things like that, that especially in primary care, to have in their chart to kind of have as like a conversation starter for subsequent visits. And then sometimes also social history can be helping us with the diagnosis, especially if they have like occupational exposures, if they're like a construction worker maybe, and they're having like respiratory symptoms after working around a specific like chemical or type of material or something. So moving on to the objective portion of the note, we are first going to look at her vitals here. And I'll have you guys just take a look at these and let me know what you think is abnormal with her vitals. So blood pressure is 92/62, heart rate 104, respiratory rate of 20, her temperature is 37 degrees Celsius or 98.6 degrees Fahrenheit, and her oxygen concentration is 94%, BMI is 22. So that's a normal BMI range. But out of the rest of her vitals, what looks abnormal to you guys if you had to take a guess? And I think if you need normal ranges, we can go over them. And also they should be in that resource drive. So Chase is saying soft blood pressure, mild tachycardia, and hypoxic. And yeah, we'll say that she is on room air, meaning that we're not giving her any supplemental oxygen to like help with her blood oxygen saturation here. So this is just all her breathing on her own. And I agree with that assessment completely. So the normal range for blood pressure that we would see in an adult patient would be around 120/80. And so we start to get worried, especially in patients who are having these sort of like distressed symptoms, that once they go below like 90/60, and she's kind of teetering right on that line, that their hemodynamic status is in trouble. So definitely we're kind of, again, borderline on a blood pressure that's low enough for us to really worry about. Same with heart rate. The normal resting heart rate for an adult is 60 to 100 beats per minute. So being slightly over that, again, kind of clues us into some possible hemodynamic instability. Her respiratory rate being high and the oxygen being low tells us that she's having some respiratory and oxygenation problems. So having to breathe at a faster rate and still not having as good of oxygen, which again, we'd like this to be as high to or close to 100% as possible, would be indicative that she's having some trouble with breathing and getting her oxygen. Temperature looks fine and BMI looks fine. So the ones that we're looking at here are the blood pressure, heart rate, and then respiratory rate and oxygen. For the rest of our physical exam, just looking at our patient and observing, like, what do they just look like when we walk into the room? She's anxious appearing and in sort of like a moderate distress. For her head and neck exam, we see this periorbital and perioral edema present, and I'll show you guys some pictures on the next slide to see what that looks like. But that's essentially like a swelling of the eyes and around the lips that can sometimes be indicative of like an allergic or inflammatory reaction. Her mucous membranes are pink and moist, and her airway, this is really important, airway is patent or open without obstruction. So we can't always see exactly, especially because, you know, your airway goes down from like your throat to your vocal cords and to your trachea. So you can't see visually sometimes, but just looking at like the back of her throat, it's not like completely closed off right now. It's open and it doesn't appear to have an obstruction. So that's actually reassuring. For a cardiopulmonary exam, she has a regular heart rate and rhythm, and she does have expiratory wheezes bilaterally. So when we have her breathe out or exhale, that's when we hear those wheezing sounds coming from both of the lungs. For her abdominal exam, it's soft, non-tender, and non-distended, but she does have a diffuse urticaria on the trunk, and urticaria is the medical term for hives. So like sort of these raised red patches that tend to be really itchy and can kind of welt and like merge together if it's in a large area of the body. Her extremities are warm and pink with a brisk capillary refill. And for her neuro exam, again, this is something really important to not forget about in a patient who might have a lower blood pressure or a lower oxygenation, that we want to make sure that they have normal mental status and level of consciousness, that they're not impaired neurologically from their hemodynamic or respiratory status. So she is alert and oriented ×3 or AAO ×3 with a normal mental status exam and has no focal neurologic deficits. So presumably her brain is still being well perfused despite this kind of lower end of the blood pressure. Here are some of the pictures that I was talking about. So we have this periorbital and perioral edema in this woman here. You can see her eyes are very puffy and almost like swollen shut. And then there's also this extra swelling kind of around the lips. Sometimes in patients with anaphylaxis, you can get like your tongue swell up really big and other structures in your mouth to swell. And these are the hives that I was talking about on the trunk. This looks like it's on this patient's back, but they can go anywhere on the body. Again, we kind of classically associate hives with being an allergic response. And sometimes they can be more like localized, like if you're allergic to, I don't know, like like grass or something, and you just like had your foot or your leg touching the grass, and you can maybe get hives just in that one area. But something that's more of a systemic reaction would have hives more widespread over the body. Okay, so continuing with our case, curious what you guys think. Given her status, her vitals, and her exam and everything, do we want to treat her now, or do we want to wait for any like results for labs or imaging or other studies? What do you like? Is this patient currently stable, or does she need to have an intervention? Chase is saying intervention is reasonable, and I totally agree. So maybe on paper right now, she has like an above 90 to over 60 blood pressure. Her airway is open, and she doesn't have any neurologic deficits. So she is currently stable enough, but these things can happen super fast, and you can go from okay to very, very sick and not doing well in a matter of minutes with anaphylaxis. So it's very important to not delay treatment, and that we give her medications to help stop the reaction and to prevent further damage before we proceed with like any further workup. So we can draw for her labs now, and then once those results are processing, we can also be like treating her, and then just follow up with what her results are to determine like if there's any additional findings from that. So the labs that we get for anaphylaxis are something called a serum tryptase and a plasma histamine. And these, as we'll learn in the pathology section of this, are going to be two things that are released from a cell called mast cells in the body. And these are really inflammatory proteins and things that are released into the body. So in a person with anaphylaxis, we would expect them to be elevated past a like normal range, what a normal person would have. And this is a graph kind of showing the time frame of like how quickly these can spike and how quickly they can fall. So a plasma histamine spikes a lot sooner after the onset of symptoms and falls a lot sooner as well. But a total tryptase or a plasma or a serum tryptase level takes about an hour to reach its peak, and then it will slowly fall over time. So we really are looking at this serum tryptase level as a way that we can confirm the diagnosis of anaphylaxis, but we're not using it as a treatment guiding measure, if that makes sense. So finishing up with our assessment and plan here, we have a 20-year-old female with a history of allergic rhinitis and mild intermittent asthma who presents with 30 minutes after a bee sting, who has sudden onset of shortness of breath, wheezing, eye and lip swelling, and then hives on the trunk. So those were kind of a combination of our history that we got from the patient and then our exam findings as well. She is hemodynamically labile, I would say, instead of stable, meaning that her vitals are in a normal range and staying in a normal range. Labile is if they're either borderline in an abnormal range, or if they're could be at risk of rapidly falling or changing in a short period of time. So hemodynamically labile on exam with a low blood pressure, high heart rate, and falling oxygenation. Her serum tryptase and histamine was drawn with elevated markers that are consistent with anaphylaxis and possible shock. So our plan for this patient, again, like in real life, we do this plan before the labs actually come back. But for the sake of this case, I just included that in the assessment. But we're going to treat her with intramuscular epinephrine and IV fluids for blood pressure support. That's like the number one most important thing to do in anaphylaxis. We're also going to give her IV diphenhydramine. You guys might know this as Benadryl as the brand name, but the generic is diphenhydramine. And this is an antihistamine that is going to help combat that release of histamine from the mast cells, which again, we'll get into a little bit later. And we're also going to give hydrocortisone, which is a steroid or something to help to give hydrocortisone versus, yeah, so you can give any corticosteroid through the IV to help kind of prolong the effect of the antihistamine and to prevent like a rebound reaction hours after the initial event. So the steroid is something that like it can be given, or you also don't really like have to give it to every patient. The most important things to do are the epinephrine for sure, and then the antihistamine. And you can also do an H2 antagonist like famotidine is the one that I've seen commonly, which can also be used as like an antacid. And that is going to help with the histamine signaling like in the GI tract. So there's a couple different types of histamine receptors, but just to keep it simple, if we just like grossly have an antihistamine like diphenhydramine, that can help with antagonizing those effects of histamine. And the H2 antagonists or the steroids, I think are kind of more institution or like provider dependent. So good question. I think both of those could be correct. And it just kind of depends on like what the patient presentation is like, what their medication history is like, and who the person treating them is. All right, before we move on to the pathology section, does anybody have any more questions about this patient's case, the plan? Don't need to go back for anything in the SOAP note at all. All right, well, we will move on to our pathology section. So just first to try to define some terms for everyone that we're on the same page. An allergic reaction is an overreaction of the immune system to an everyday non-threatening substance. So things that normal people should be able to eat or be around without their immune system thinking that it's like a foreign invader is really perceived by the body as something that needs to be like eliminated and to, you know, get out of your system. So you can have allergies to food. We all, you know, peanut allergies are really common these days, eggs and wheat, fish, shellfish, dairy. Those are kind of the main food allergens that we see. They can also be environmental, like pollen, grass, pet dander, mold, a lot of things. And even things that are like in a healthcare setting, like latex or medication allergies, especially to like antibiotics. These can all trigger allergic reactions that we should, in most people, be able to give or have them exposed to without consequence. But in someone with allergies, they overreact to it. So the reactions can range from really mild, just like some sniffly nose, maybe some sneezing, maybe some itching, to more moderate, like maybe if you have like eggs, you get really bad like stomach cramps, or you have vomiting and diarrhea, things like that, to severe and life-threatening like anaphylaxis, where you have breathing problems, swelling all over your body, and compromise of your airway and your hemodynamic status. So allergies in themselves, especially like hay fever or allergic rhinitis, are very, very common in the US. It's estimated that it's up to 10 to 30% of the US population has suffered from allergies in some degree. But anaphylaxis is a lot more rare. And this is an acute systemic allergic reaction that can progress rapidly in minutes to hours to airway obstruction, hemodynamic collapse, and death. So Again, this moves very quickly. We want to treat it as soon as it's recognized and have the person seek care in the emergency room so we can give them things like additional epinephrine. Usually these people, if they know they have an allergy, they carry like an EpiPen or an epinephrine auto-injector on them so that they can self-administer the epinephrine from home or wherever they have their onset of symptoms. But sometimes you need more to be given over time. And sometimes you need additional support, like you might even have to intubate the patient to secure their airway or give them other medicines to keep their blood pressure up and things like that. So the estimated occurrence of anaphylaxis is only about 0.5 to 2% of the US population. And it's, varies by country and over the world and stuff, but this is just in the US. The incidence and prevalence, meaning the total number of people with allergies and the rate of new people who are being diagnosed with allergies, are both increasing over the last few decades. And something that people have been asking is like, what's causing this? Why do people get allergies? And is there anything that we can do to like prevent allergies? And there's something called the hygiene hypothesis, which I was taught in my immunology class as kind of like the most accepted hypothesis as to why people are experiencing more allergies. It's not like evidence-based entirely, and it's definitely not like a proven reason why. It's definitely multifactorial, but this is just one element to it that I wanted to talk to you guys about. And it's the idea that decreased exposure to microbes or antigens and proteins from your environment in early childhood or early immune development will eventually lead to decreased immune tolerance of those substances every day when they're later introduced. So think of like, I'll use myself for an example. I have really severe peanut and tree nut allergies, and I also have a ton of environmental and like pet allergies and stuff. And anecdotally, and again, this is not like entirely rooted in evidence, but my parents were extremely strict about what I was able to eat growing up, like as a baby and as a toddler. And we're also very, very like sterile and clean about the toys that I played with or pacifiers and things like that, that they would either get like boiled or bleached if they fell on the ground. And I wasn't, taken to people's houses if they had dogs or cats. And at that time, like that was the recommendation, was to avoid introducing especially like food allergens that can cause really serious reactions in kids who are not like don't have a fully developed immune system, because you wanted to like avoid having a reaction when you introduce that to them. But the idea now is that since we're seeing more people who have food allergies and allergies to their environment, that the American Academy of Pediatrics recommends introducing those major food allergens early and often once you're able to give solid foods to babies starting, I think it's around 6 months. And I won't get into like the details of it, but essentially they want you to have that exposure earlier on so that your immune system will be able to recognize this as a non-threatening and non-harmful substance, so that later in life, when you are exposed to it again, your body doesn't like freak out and send you into anaphylaxis. So it's kind of striking a balance of course, we want to have a clean environment. We want to not spread like transmissible diseases and stuff, but we still want to have enough exposure to the things around us that our bodies don't freak out about it. So going into our pathology now, there's actually 4 different types of hypersensitivity reactions in immunology, but I just want to focus on type 1 because this is like the classic allergic hypersensitivity. So just know that there are 4 different types, but type 1 is going to be what's called either a mast cell or an IgE mediated hypersensitivity. So the way that it works is we have an allergen that we're exposed to, and a cell in our body is going to like pick up on that allergen and tell our T cells and our B cells to produce antibodies against it. And the class of antibodies that are produced against allergens are called IgE, and Ig stands for immunoglobulin. But it's similar to a lot of different antibodies that we have like the mechanism of how they work. It's that these two little prongs here at the top of this Y-shaped molecule are going to bind and like look out for the actual structure of the protein or the antigen in the allergen. Similarly to like the antibodies of a vaccine or that are produced from exposure to a vaccine would recognize viral or bacterial components. Except these are going to be able to recognize things like a bee venom or peanut protein or something like that. And mast cells, which are those immune cells that I talked about earlier, they express these IgE antibodies on the surface of the cell. And so when an allergen is introduced and binds on these IgE receptors, it's going to trigger this mast cell to do something called degranulation. And the mast cell is filled with all of these little dots that are granules filled with enzymes and other cell signaling molecules and things like that. So I have a list of them here, but I just wanted to make sure that everyone kind of understands the process of having allergen. This is your initial exposure. Prime your immune system with your T cells and B cells to make these IgE proteins. And then later when you have exposure to an allergen again, and the IgE proteins are expressed on the mast cell, that's what causes the reaction to occur by this degranulation. So a lot of large terminology there, but to go further into detail about what's released in the granules. So the one we've talked about already is histamine. This is definitely the major player in an allergic reaction and the main thing that's released from the mast cell. And histamine has a range of things that it causes, but in short, it causes inflammation and swelling. And I'll show you again on a couple of slides the mechanism for that. They can also release things called leukotrienes, which can cause bronchoconstriction and cause that wheezing and shortness of breath in the lungs. They have something called heparin, which some of you guys might recognize as a medication that we give as a blood thinner to people who have blood clots. And your body does actually make heparin, and it can be released from mast cells to increase the blood flow to the area that's affected. Similarly, with nitric oxide, this is a vasodilating molecule that's going to make your blood vessels go from a more normal, like smaller size to really, really big. And when that happens, your blood pressure goes down. Prostaglandins can cause smooth muscle contractions. So this can contract the smooth muscles around your airway, so like your bronchi, and produce kind of like an asthma-like presentation because of the smooth muscles that are contracting in the lungs. And they can also cause smooth muscle contractions in the GI tract. So some people with their allergies, they get like diarrhea or vomiting because you're really like moving everything through your GI tract very, very quickly. And then the last thing, just to kind of bring us back to those labs that we looked at before, is tryptase. So you also have a lot of proteases and like other enzymes that are released, and one of them is tryptase, which is a protease byproduct of degranulation. So seeing an increased tryptase level on a person who has anaphylaxis just kind of confirms that the origin of their symptoms was due to a mast cell degranulation in the body. So a lot of things here, but the main ones, again, to focus on are histamine. Really, histamine is the main one that we think of. So some signs and symptoms of anaphylaxis, we kind of saw this in our patient in their exam, but we can get tachycardia and hypotension. And the reason that we see this is because with that vasodilation, you get really large blood vessels that have a low blood pressure, and that can decrease perfusion to your organs, especially to your brain. It can cause you to faint, lose consciousness, have altered awareness of your surroundings and things like that. And so to compensate for that, your heart is going to increase its rate to try to pump more blood to your organs and to the rest of your body. We kind of talked about for the respiratory, how you can have bronchi swelling and vasoconstriction, smooth muscle constriction. around your lungs, causing an asthma-like presentation. But then you can also have more proximally or more up by like your throat, some airway swelling and some like just obstruction of the airway. And so for both of these reasons, you see sometimes an increased respiratory rate or tachypnea, which is fast breathing, to try to, again, get you more of that oxygen and to combat that your lungs and your airway are not able to pass as much air through. And then lastly, for your skin and your tissues, you can get swelling and hives, sometimes like secretions in like your GI tract and stuff. And that's secondary to increased vascular permeability. So normally your blood vessels are have kind of a nice seal on them, and they're not going to let a lot of fluid leak out into the rest of your tissue. But these cell signals that we had on the previous slide, these ones can also increase your vascular permeability and leak fluid into your tissues. And that's what causes like that extra swelling that we see around the eyes, around the lips, in the airway possibly, and give you like hives and things like that on the skin. So just showing at the blood vessel level what histamine can do to it. So one is that the capillaries or the blood vessels are going to widen, and that's going to allow for increased blood flow, and you can get heat. So like if you touch a hive on someone's skin, it's usually really hot. It's usually really itchy for them too, and not comfortable. Another thing that happens, like we just talked about, is the increased vascular permeability. So you release fluid, which is really plasma with not like cellular components, into the tissues, which can cause redness and swelling. Some of those cell signaling molecules that we went over on the hypersensitivity slide can also act as attraction of other white blood cells or leukocytes, and that will recruit other immune cells that will increase the inflammatory response even more to the site of injury or to the site of where the allergen was at. And then for systemically, we're just going to have like an overall increase in our immune response and in our inflammation, which can cause, fever, pain, and that drop in blood pressure that we're really concerned about. So the definition of shock is a massive drop in blood pressure that leads to a decreased perfusion of organs. And so if you don't treat anaphylaxis and you have a really low blood pressure and you're in anaphylactic shock, then you can have decreased blood flow and organ failure to like your kidneys, your brain, your heart, your GI tract, things like that. So it's really important to keep that blood pressure up as into a stable range. And that's what the epinephrine is going to do. Like I mentioned, it's caused by that widespread vasodilation. And so you are actually still getting blood flow to like your extremities. Like if you did like a fingertip capillary refill where you see how quickly, if you like turn your fingernail white by pressing on it, how quickly does it go pink again? In some types of shock, like where you have a low blood volume, if you bled a lot, or if you have cardiogenic shock where your heart isn't pumping enough blood out to your body, then we would see the opposite of that, where your capillary refill is really slow because you're not getting as much blood flow to your extremities. But in anaphylactic shock, we can see still that you have a lot of blood flow and you're just leaking a lot of fluid out into your tissues. So your capillary refill can look really good, but that doesn't mean that you have like still good circulation of oxygen and of the rest of your blood cells that you need within the blood vessels. So talking about the treatment of anaphylaxis, we've already kind of gone over all these medications and how you can have some variation in like the steroids that you give and the types of antihistamines that you give. But the basic ones that we are going to cover for the sake of this case, because that's what our patient received at the beginning, starting with epinephrine. So every person who has suspected anaphylaxis is going to get epinephrine, even if their blood pressure appears normal. People can just give themselves epinephrine if they have a diagnosis of an anaphylaxis or an allergy that can cause anaphylaxis, and they can just give that to themselves when they feel that they need it or that they're having a reaction. And the mechanism for this is that it's going to help combat that vasodilation that happens from all of that histamine release. And it's going to help to vasoconstrict your blood vessels back to their kind of normal size. So instead of having them be like really, really big and gaping open, it's going to help increase your tone of the blood vessels and bring them back to a normal size so that you have better blood pressure. So that's going to help blood flow and perfusion to your organs, like your brain and your heart and the rest of your organs in your body. And it can also, as a secondary effect, have helping to relax the smooth muscles in your lungs and in your airway to help with your breathing symptoms. Again, the thing that's really going to nip it in the bud from a reaction standpoint of like your hives and your swelling and stuff is the diphenhydramine or the Benadryl or any other antihistamine. So you could do like a Claritin or a Zyrtec or a famotidine for if you want to do like an H2, which I don't want to get into that pathophysiology or the pharmacology of that, but an antihistamine is going to block those inflammatory effects of histamine. And this doesn't have to just be given in anaphylaxis. A lot of people who have just seasonal allergies or like environmental allergies can take an antihistamine every single day even. Like I take a Zyrtec every day, and that helps to reduce the amount of like sneezing or watery eyes or itching, things like that you would have just from exposure to those other allergens. So it's going to help reduce all of those symptoms, and it'll actually terminate or like help to terminate the actual reaction for your allergen. And then the role for steroids, which you could give prednisone, hydrocortisone, any number of corticosteroids. So not as important about the name of the steroid, but just that this is an option, is that it can help further slow and reduce the inflammation. But it's a lot slower acting and it's a lot longer acting. So it shouldn't replace any of these other drugs, but you can co-administer it to try to prevent delayed onset of reaction or a rebound reaction. So sometimes even if you treat and get things under control with epinephrine and diphenhydramine, if the amount of the triggering allergen is still in the body, that can cause an additional reaction after those medicines have worn off, that this can help try to prevent that. But again, it's not a replacement for these other things because it's so slow acting. So to kind of go into a patient update, she does follow up in the allergy and immunology clinic and is confirmed to have a bee and wasp venom allergy with skin testing. So skin testing is something that they can do outpatient in a clinic, in an allergy clinic, and they are essentially taking the antigen or the protein component of a bunch of different types of allergens, food allergens, environmental allergens, medications, I think maybe even, I'm not sure. And they assign like each dot on the back a specific thing that you can go back to your chart and see like, okay, what swelled up here? So like presumably these two in this patient, like this obviously isn't real, but that these would correlate with like a bee and a wasp venom, and that the other things that they looked for, this patient didn't react to. So she's prescribed an epinephrine autoinjector to carry with her at all times in case of a anaphylactic reaction, and is instructed to come to the ER again as soon as possible if her symptoms recur. So say she's like on a camping trip and has another bee sting, that she can have that epinephrine on hand with her, like right where she is, and use it as soon as she needs to, and not have to wait to treat until she gets to the emergency room. I always like to wrap these up with a little bit about the specialty that we talked about today. So going into some allergy immunology stuff. These are specialist physicians and scientists who are experts in the diagnosis and treatment of allergies, asthma, and other immune system problems like immunodeficiencies even. They work mostly in a clinic or outpatient setting, as there's really not that much like inpatient allergy problems. People can come to the emergency room for allergic reactions, but they're treated by an emergency medicine physician, and people don't really get like admitted for anaphylaxis. So you do a lot of mostly like clinic and outpatient work. And you can work with either adults or children, depending on if you do a pediatrics or adult medicine residency. And the thing about allergy immunology that's really cool is that it's has a lot of opportunities in research. So you can take a path where you practice clinical medicine, where you get your MD or DO, do 3 years of residency either in internal medicine or pediatrics, and then your fellowship training in allergy and immunology is going to have both a clinical component where you have like subspecialty clinical experience with that field, and usually you have a extensive research project as part of that training. And sometimes you can even do an entire designated year of research as part of your fellowship. If you don't want to practice clinical medicine, but are still really interested in immunology, it is a super cool field, and it integrates or like intersects with a lot of different specialties in medicine, particularly like cancer, oncology stuff, vaccine research, autoimmune diseases, and rheumatology, those types of things. So if you want to focus a lot on research and not work with patients directly, you could do a PhD in immunology, which would probably take around 4 years, do some postdoctoral training in a lab, and then you would work as a PI to study these things directly. So those are a couple different pathways to immunology. And both of them are going to have a good research focus, and eventually, be able to affect and impact a lot of patients. So if we didn't have PhD immunologists, we wouldn't have vaccines, we wouldn't have really amazing cancer immunotherapies and things like that. These are some of my sources. And that pretty much covers it for today's session. I know we're done a little bit early, so I wanted to make sure that you guys had opportunity to ask any questions, especially in the second half with the pathology. It's a lot of big terms and complex like cellular reactions that we talked about. But I'm also happy to chat about anything related to medical school or applying to medical school or anything in that realm. And as always, as you're working on your SOAP note and quiz, if you need to go back to any of the slides, I'd be happy to do that as well. So thank you guys for coming. I'll be around if you have any questions, and I'll just kind of wait until people are done on the call. And if you don't have any questions and you feel good about your SOAP note and quiz, then you can feel free to log off at any time. Avery is asking, is it possible to do both adults and children? I think it is possible, actually. I think to work with adults, you would for sure, or I guess, sorry, this is anecdotal because my home allergist in the town that I grew up in, he did internal medicine residency. And I saw him when I was like a teenager. So I was technically still under pediatric care, and was seeing an adult trained allergist. I think if you wanted to work with both adults and children, it would probably be better to do an internal medicine residency. And then rather than do pediatrics, because then I think you would be really limited in your ability to work with adults. And it also really depends on the institution that you're at. So at a smaller, more community or like private practice type setting, then I think you could probably have more flexibility depending on what your pathway is, versus if you're at a really large like academic medical center, like at a university, they're going to have special clinics for both pediatric and adult allergy immunology. So depending on what your practice goals are, I think you have possibly like the flexibility to work with both of those types of patients. but you might have to work in a smaller type of clinic in order to do that. So Chase is asking, give us a quick and easy rundown on anaphylaxis versus anaphylactoid. Listen to a podcast on contrast and mediated AKI. Okay, yeah, so that's a great question. So from my understanding, anaphylaxis is like a true allergy response to something that is like a food or like a protein from a medication or something. And other agents like contrast can induce similar type of symptoms that present almost identically in a clinical way. So they would have the same types of physical exam findings. They would have the same like mast cell degranulation, but the trigger for it is a little bit different. One thing that comes to mind for anaphylactoid type reaction is something called an amniotic fluid embolism, which is a really, really scary, life-threatening complication that can happen to women who are giving birth, like in labor and delivery. And so that's where like you're not ingesting or exposed to a foreign protein per se, but it's material from the amniotic fluid that enters the bloodstream and can cause an anaphylactoid, meaning similar symptoms. And we would treat it the same way with epinephrine, with making sure we have a secure airway. But because you're not introduced to like a new antigen from somewhere else in the environment, we don't classify it as straight up anaphylaxis. So that's the extent of my understanding. I don't know if that's like a satisfying answer for you or not. But it's definitely, I don't know. I think like we're moving away from calling things anaphylactoid because people would think that it's like either not as serious or like not real in some way, but the true pathology is very similar, the treatments is very similar, and so we want people to understand that like it's not like a pseudo anaphylaxis, it's like a real reaction, and we need to make sure that people are getting the treatment they need. So good question. What other questions can I answer for you guys? Okay, so another question about a PEDS patient who had swelling around their eyes, and it was described as anasarca versus angioedema due to oncotic pressure. Yeah, so that's getting into a lot more complicated pathophysiology that I'm happy to chat with you about. Just for other people that are on the call, like don't worry about this if it doesn't make any sense. But the idea with anasarca is it's a form of like pitting edema that happens when you third space fluid from having a low oncotic pressure. So you have either like a low sodium content in the blood or like low protein in the bloodstream, and because of that you're displacing free water from the blood into other parts of the body. So we see this a lot in people with like heart failure or renal failure, so like nephrotic syndrome, where you are basically like it can start lower down in gravity dependent parts of the body. So like your feet and your legs are the first place to usually show this pitting edema. But in really uncontrolled cases, it can go really high, like it can go up the legs into the abdomen, like you can like press on the skin or the tissue, and you have this like pitting mark from where the fluid was displaced from that part of the skin, and it doesn't like fill back up immediately. I think maybe actually what I'll do is let me see if I can find either a picture. Yeah, so this is showing in the legs, which is again the most common area, but you can really have this go all the way up the body. And again, the cause of it is what's the word that I'm looking for? A low oncotic pressure edema, where you have a movement of fluid out of the blood vessels, out of the vasculature. So a lot of plasma fluid that goes out into the interstitial space of the body. And that can be caused by, sorry, I'm getting really distracted. That can be caused by either like a low oncotic pressure or a low hydrostatic pressure, which would be like the amount of solute that's in the blood. So I don't know if that was super helpful. It can be difficult to untangle on physical exam. Somebody who has like a periorbital edema, just looking at them, if like you're looking at their face and they have swelling around the eyes, it can be due to something like nephrotic syndrome, which is a kidney disorder, kidney disease, where you have a abnormal fluid balance in the body. And so what's going to help you determine the cause of that is looking at the whole clinical picture, and like, what do their labs look like? What does their history look like? Do they have edema like this in other parts of the body? That would point a lot more towards it being not like an anaphylactic type reaction. Has it started like days ago, or has it been happening for a long time, versus did it just start happening like within the last few minutes or hours? Those can be things that you do to kind of distinguish between different causes. And also anasarca is, I don't know if I mentioned it, but from my understanding, it's just like a really severe form of pitting edema that can go up the entire body. One example from experience that I have is a guy who had really bad heart failure, and his edema went kind of up to the level, like around belt level, or around the level of like the hips. And so his scrotum was extremely swollen and full of fluid that, again, it's not supposed to be in that space. And he was just like in so much pain, and I felt so bad for him. But really the treatment for those types of swelling or pitting edema is you have to diurese them and get all that fluid to come off by having them excreted into the urine. So again, if you can't do that because of kidney problems, then it just builds up in the rest of your body. Not comfortable. Yeah, and again, with these things, I hope I'm doing like at least a somewhat good job with answering them, but you could probably find some good videos on YouTube explaining the pathophysiology of them. If you're already like at that level before even starting med school, then that's really awesome. I had no idea like even what edema was, like what that term meant, or what the different physical exam findings meant in terms of like the cause of things until I was far into medical school. I had never heard of anasarca until I was like a second or third year med student. So if you're interested in getting probably a better explanation, then you could probably find a good video on YouTube to kind of walk you through it in more detail. But that's pretty much the extent of what I know.